to any other books in the market, in the conventional books that we are used to go through. But this is the most accurate, most updated with all recalls. So I have talked about critical care station previously, so I don't want to lengthening my speech on critical care. We'll just directly go to our studies. So these are the stations. So we'll try to cover first 4 or 5 stations tonight, and these are the most important. That's why I kept those stations at the very beginning of the class. So let's start our journey. So this is our first question. So let's read out the question. So at first, first term, 45-year-old man admitted to hospital with a history of haematemesis on examination, jaundice, and ascites. And ethanol abuse. After 2 episodes of the haematemesis, he became confused. Blood pressure decrease, heart rate increase, lab results are available. So whenever you are going for the station, you will come to see this station, and some other information might you get in the question paper, but is the most appropriate. So this is one scenario. So there are so many things that have already mentioned here. The patient is history of haematemesis, jaundice, and ascites. And patient is alcoholic. 2 episodes of haematemesis, he become confused. This is another point. Blood pressure decrease, heart rate increase, and labs are available. So there are another 2 steps. So what is your diagnosis? So at first come to what is your diagnosis? So what is your diagnosis? What could be the diagnosis is? So guys, is there anyone who can say what is your diagnosis?
Due to portal hypertension.
Okay. Portal hypertension. Okay. So at first we'll go how, as the patient is cirrhotic, how portal hypertension develops in this case. So let's come to the pathophysiology. So this is the portal vein, and this is the portal vein. Come to this one. This is the portal vein. And whenever portal vein inserts into the liver, it produces some sinusoids. All of you know the sinusoids, right? So these are the hepatocytes. These are the hepatocytes. And these are the bile canaliculi or bile ducts. So a type of cell which is called stellate cell that remains in the perisinusoidal space, and this is called perisinusoidal space. So whenever a patient become alcoholic, the hepatocyte become inflamed. And this hepatocyte ultimately leads to activation of the stellate cell.
Picture.
Guys, can't you see the picture?
What is the...
Who is talking here? Dr. Salaman. I think Dr. Salaman, please, would you stop your camera and you can, okay, that's good. So here, whenever hepatocyte become inflamed, this activates the stellate cell, and stellate cell is that kind of cell. Those things will produce a factor that is called TGF, transforming growth factor beta. What is called? Transforming growth factor beta. And transforming growth factor beta stimulates the production of some extracellular matrix, and it ultimately leads to fibrosis. So again, I am starting. Whenever a patient become alcoholic, these sinusoids become inflamed, these sinusoids become inflamed, and these are hepatocytes. These hepatocytes become inflamed, and this is the sinusoid, and this space is perisinusoidal space, and this is called stellate cell. So whenever patient become alcoholic, or alcohol stimulates the or inflame the hepatocytes stimulates the stellate cell here, perisinusoidal space, and stellate cell produces transforming growth factor beta, and it produces some extracellular matrix, and extracellular matrix become fibrosis. So what happens ultimately? The thing that will happen subsequently, I'm writing the subsequent picture of this one. So these are the sinusoids. So this space become narrowed. This space become narrowed, and there will be so extracellular matrix collagen here. Will be dilated portion, and these are the hepatocytes here. These are the hepatocytes here. So as there is a so fibrosis, so these vein become compressed ultimately. So as these vein become compressed, the draining veins or sinusoids will be compressed or swelled up or distended. Guys, compressed or distended? Compressed or distended?
Compressed.
Yes. So this portion will be compressed, and this one is the draining vein or portal vein. So portal vein can drain any more blood, right? So what will happen next? As fluid can be drained out, so patient will at first will develop portal hypertension. Portal hypertension. So patient will develop some portal hypertension, and portal hypertension develop the fluid that remains here that can go any further spaces, and this portion from here, the fluid from the blood will seep out into the peritoneal cavity, and ultimately that leads to what is called
Ascites.
ascites. Exactly. That will lead to ascites. So, and the previous portion, this portal vein, how the portal vein is formed? Is there anyone who can mention how the portal vein is formed?
Splenic vein and
Splenic vein and
Splenic
superior
vein and
mesenteric.
superior mesenteric.
Exactly. So splenic vein can drain any blood. So the blood from the spleen can go to the liver as this portion is obstructed. So spleen will become congested, and it is called congested splenomegaly. So second portion is called congested splenomegaly or hypersplenism. Hypersplenism, right? So now come to this portion. As these blood can drain further, so all of you know this is the liver, and this is the portal vein. As liver has already been cirrhotic, so blood can go through the liver, and it ultimately from the liver it goes into the inferior vena cava by the hepatic vein, right? This is the normal pathway. But whenever this liver becomes cirrhotic, this blood can go to the liver. So this will go into another circulation, collateral circulation, and another systemic vein directly, not through the liver, and this is called portosystemic shunt. What is called, guys?
photosystemic shunt.
Portosystemic shunt.
Shunt.
Portosystemic shunt. So come to the portosystemic shunt. Whenever portosystemic shunt occurs, as I have already mentioned that normal, guys, all of the class will by this way, and after the discussion of the topic, you'll come to know that your all the stations have already been done. I know how to teach the doctors, so nothing to worry about. Just focus on the concentration, because critical care is the most easiest one. If you go through the every single step clearly, so that will nothing. But if you don't focus on an understanding, then it will be a big burden for you, right? So normal.
Excuse me, sir.
Yes.
I joined at exactly 10 and the class had already started. Could you just tell me the topic, please? I'm so
This is the
sorry.
first one. This is the first one. Esophageal varices.
Okay.
Esophageal varices.
All right.
So,
Thank you, sir.
okay, that's great. So, as I was saying that this is the portal vein. So, liver has already been cirrhotic. So, blood can't go to the liver. So, it was used to go in the inferior vena cava by the hepatic vein. So, this pathway is altered. So, it will follow another veins and directly to the systemic vein, and this is called a portosystemic shunt. So normally the normal venous pressure, portal venous pressure, every single thing you have to note down is 5 to 10 milliliter of mercury. But when portosystemic shunt occurs, in case of portosystemic shunt, the pressure is almost 10 to 12 milliliter of mercury. And in case of this pressure, when it rises beyond the 12 milliliter of mercury, it will produce some varices. So how varices form? Because I already mentioned that this portal vein have to drain here the blood, but as it can't drain the blood here, so it will follow another way and it directly drain into the systemic circulation, and that's why it is called portosystemic shunt, and it will follow another way, right? That's why the systemic some portal veins, like the left gastric vein, come to the left gastric vein. This is the left gastric vein. Come to the left gastric vein. This is the left gastric vein. This is the left gastric vein. Left gastric vein goes to the portal vein directly. And from the left gastric vein, there is a esophageal vein, and this is the esophageal vein. So all of you know that whenever the portal hypertension increase, the esophageal vein can drain the blood to the portal vein. That's why this vein become engorged, right? This is the reason why esophageal varices occurs. Did you get my point, doctor? Did you get my point, doctor?
Yeah.
Okay.
Yes,
So
I guess.
now come to the portosystemic shunt. So this is the portosystemic shunt. So whenever portosystemic shunt develop, the body will identify that there is some problem has already been happened in the body. That's why liver can get the blood. That's why the body will produces some nitric oxide from endothelium. So I am telling that when potassium shunt occurs, body will come to know that liver is not getting blood. That's why body will produce some nitric oxide. You know this is the most important vasodilator of the body from the endothelium. So whenever the nitric oxide produce, what's the role of the nitric oxide? Vasodilatation. So vasodilatation will occur. So whenever vasodilatation will occur, all the vessels will dilated, right? Right. So when all the vessels will dilated, the renal perfusion will increase or decreased?
Decreased.
Decreased, because all the blood has been distributed throughout the body. That's why as the kidney itself is a very vital organ, so this blood level will be decreased. That's why the renal perfusion will be decreased. So decrease renal perfusion. So whenever renal perfusion decrease, as all of you know that when renin is secreted, is a this is a nephron, and this is the efferent arteriole, and there is a cell here. This is called JG cell. JG cells. The role of these cells to produce renin. So what is the role of this cell to produce renin? And when renin is secreted, all you have to remember, it is secreted when blood volume is decreased. Blood volume decreased. So come to the again this point, nitric oxide is synthesized from the endothelium, vasodilatation occurs, all the vessels will be dilated. That's why renal perfusion decrease. That's why renin JG cell will get less blood. That's why renin will be secreted. Right? Are you here? Getting the point?
Yes.
So
Yes,
when renin
sir.
is secreted, this will produce renin angiotensin aldosterone system. Right? This produce renin angiotensin. And renin angiotensin aldosterone system, ultimate product is angiotensin 2, and angiotensin 2 itself is a potent vasoconstrictor. Potent vasoconstrictor. So, see this point. Patient is already been renal hypoperfused, and still after getting the renal hypoperfusion, patient will produce more renin angiotensin allogenous system, and ultimately angiotensin 2, and angiotensin 2 will produce vasoconstriction, especially renal vessels. So kidney is already hypoperfused. For this reason, this will produce angiotensin 2, and it will potentiate the vasoconstriction more and more, potentiate the vasoconstriction more and more. So what will be the condition of the kidney? Whether the kidney will be improved or deteriorated?
Deteriorated.
Exactly, deteriorated.
Deteriorated.
And that ultimately lead to AKI, and this condition is known as hepatorenal syndrome. Hepatorenal syndrome. Did you get this point, doctor? Okay, come to this point again. So we have already mentioned that how cirrhosis occurs, how portal circulation, portal hypertension occurs here, how the venous engorgement dilatation occurs, how the congested or splenomegaly occurs, how portosystemic shunt occurs, and when portosystemic shunt occurs, nitric oxide produces, vasodilation is become dilated, renal hypoperfused, and this will be potentiated by angiotensin 2 and ultimately vasoconstriction, and it causes AKI, and this condition is known as hepatorenal
Hepatorenal syndrome.
syndrome. Very good. Very good. So what is the triad? I'll come to the another point. What is the triad of the uh, portal hypertension? What will happen as we are saying that this is a portal hypertension is here? So what is the consequence of the portal hypertension? There is one consequence, just I am writing his here. We have already mentioned that here is ascites, one of the consequences. Another one is splenomegaly, and another one is varices. These are the triad of portal hypertension. So I have mentioned all of these, why varices occurs here, why splenomegaly occurs here, when ascites occurs here. Did you get my point, doctor?
Yes.
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 Okay.
Yes.
Now come to I will come to another point. I hope this was the number 3, and come to the fourth point. Fourth point, the function of the liver is to detoxify. Function of liver is to detoxify of toxins. Right. So whenever patient's liver become cirrhotic, will it be able to detoxify the toxins?
No.
Exactly, no. And especially there is no metabolism, no Krebs cycles, or no Cori cycles, what are the cycles those are, especially the ammonia plus other toxins can't be neutralized, can't neutralized. So this ammonia will go to the brain, goes to brain, and this will affect the neurons, and that will cause some condition that is called S-6, and that will have to look for the abdominal examination or respiratory system examination and whatever the condition is, and ultimately that will cause some CNS symptoms plus coma, and that is called hepatic encephalopathy. What is called, doctors?
Hepatic encephalopathy.
Hepatic encephalopathy.
Exactly, hepatic encephalopathy. Now come to the fifth point. Another function of the liver is to metabolize estrogen. Please, if you can't understand my writing, I know very well my writing is very worst, but okay, just just write, go through the net, no problem. X-axis. So what is metabolize the estrogen? So whenever liver become cirrhotic, the estrogen can be metabolized. So increase estrogen in blood. So that will ultimately lead to gynecomastia. Gynecomastia, spider nevi, and ultimately Palmer erythema. Guys, all you have to look for this thing I am mentioning here in the clinical examination. So try to clear your conception from here so that you don't have to remember again and again from the examination portions. So whenever liver become, this point was fifth point, now come to the sixth point. Whenever liver become cirrhotic, it can conjugate, can't conjugate the bilirubin. That's why in case unconjugated bilirubin, I will go through the bilirubin and jaundice very properly at the fourth station, and we'll come to know everything, and this thing will be very easy for you. So when and that's the unconjugated bilirubin, conjugated bilirubin will increase, and ultimately causes jaundice. So come to most important point, the function of the liver, to produce albumin. So the albumin will be increased or decreased? Decreased. So whenever the albumin is decreased, one of the function of the albumin, most important function, is acts as a colloidal osmotic pressure. Colloidal osmotic pressure. So the colloidal osmotic pressure will be decreased. That's why it will produce edema or ascites. Edema plus ascites. Now come to eighth point and the most important point of this portion, the function of the liver to produce some clotting factors. Clotting factors, especially almost all clotting factors is produced from the liver, especially some clotting factors, those are 2, 7, 9, and 10 are produced in the liver. And these are called vitamin K dependent clotting factors. What are these things are called? Vitamin K dependent clotting factors. So when these clotting factors won't be produced from the liver, That's why this clotting factor will be decreased from the liver or won't produce it. That's why this patient will produce, what will patient produce? Hemorrhagic disorder. And these are the most important consequences I have gone through. Still now, what will happen after the cirrhosis? What is the consequences of the cirrhosis? Now, come to the question again. 45-year-old man admitted in the hospital, history of the hematemesis. Haematemesis, I have already mentioned that the portal hypertension occurs here. That's why ultimately varices occurs here. That's why places become ruptured when it goes to the beyond this normal pressure. This become ruptured and hematemesis occurs. On examination, jaundice is present here, and patient is aside. There will be some ascites, and patient is alcoholic. Second episode of hematemesis, patient become confused. Why confusion occurs?
Hepatic encephalopathy.
Exactly, it's the one of the
Due to
reason.
hepatic encephalopathy.
Exactly, blood pressure decrease and heart rate increase. So these are the signs. So what is your diagnosis right now? What is your diagnosis right now? So our diagnosis was
Chronic liver disease.
exactly
Alcohol-induced chronic liver disease.
exactly. That's why our diagnosis was chronic liver disease, and that might be patient is having hematemesis. That might be rupture of the esophageal varices. So the examiner will ask you right now, what are your most concern regarding the patient? As the patient is ongoing bleeding and patient is cirrhotic and patient have some coagulation disorder. So the first concern, first concern will be ongoing bleeding.
Humorous control.
Control of bleeding.
Ongoing bleeding is the most concerning point as the patient is cirrhotic and clotting disorder. Then what are the other likelihood complications? One is, I have already mentioned that patient will develop AKI or hepatorenal syndrome, and that ultimately AKI, and that is also called hepatorenal syndrome ultimately. And another one is patient may develop hepatic encephalopathy. So now, anyone of you, please just answer me. What are your concern regarding the patient? Whenever they will come to me with this scenario, what are your most concern about this patient?
Ongoing blood.
Exactly, and definitely will have to mention that patient is cirrhotic, and there might be some clotting complications or clotting abnormalities. Exactly, coagulopathy, right? And other complications, AKI, hepatorenal syndrome,
AKI and hepatic encephalopathy.
encephalopathy, right? Now, the examiner will ask you, what are the other differentials may happen? What are the other causes of the esophagus? Other causes of the hematemesis. So at first, our diagnosis is rupture esophageal varices, rupture esophageal varices. Second one is mallory-Weiss tear. Mallory-Weiss tear. Could you tell me what is mallory tear?
Yes. In
What is this?
closed glottis.
Longitudinal tear of the lower part of the esophagus due
Tear
to
of the
forceful bleeding, forceful vomiting.
Yes, is this mainly happens due to tear of the only mucosa, nothing else. Only mucosa. Due to
Yes.
tear of the mucosa, only mucosa, and especially patient is chronic vomiting, retching, coughing, and staining. This mucosa may become teared, and there will be some blood, and that is called malarious tear. Our third differential is Boehver's syndrome. Boehver's syndrome. So what is this?
Perforation of the lower part of the esophagus.
Basically, here all the layers become ruptured, or tear. So here is the only mucosa, and here all the layers, right? And our fourth differential is bleeding, peptic ulcer, peptic ulcer disease, right? So these are the differentials. Now the examiner will ask you how would you manage this patient, and this very important. How would you manage the patient? And guys, you'll have to mention this because management is the most important thing you will ask definitely in this patient. So it's the most important management. Always in case of critical care management, you will have to mention, I would manage, just try to make is into your habit. I will manage the patient according to the care of critically ill surgical patient protocol. Care of critically ill surgical patient protocol, you will have to start your management by this way definitely, and there you will have some mark to mention only this word in your management of the patient, right? So there are some their management is divided into three parts. One is active management, another one is assessment of the coagulation profile or coagulation status of coagulation. As you know, the patient is cirrhotic status, and at third, our main concern, control of bleeding, So all you know that how the active management is done in case of patient. You will have to give the patient oxygen. You will have to give the patient two wide bore IV cannula. You will have to send the blood for the full blood count. You will have to give the patient fresh frozen plasma, give the patient some platelet. You will have to cross matching, or all the things you will have to do, and this is the active management. But mainly you will have to mention oxygen you will give to high flow oxygen, to wide bore cannula, and blood transfusion. These are the most important, right? Now come to the assessment of the coagulation status. Coagulation status, you will have to look for the prothom mean time. Could you tell me why prothom mean time is seen here? Prothom mean.
Vitamin K dependent clotting factor are
Prothom
primarily
mean,
responsible for the
is which clotting factor? Which number of clotting factor? Prothom mean?
factor 2.
Number 2. And number 2 is the, just write it down or just try to memorize. Number 2 is called essential clotting factor. First 4 clotting factor: 1 fibrinogen, number 2 prothrombin, number 3 tissue factor or thromboplastin, and number 4 is called calcium. These are the 4 clotting factors. These are called essential clotting factors. These clotting factors are called essential because if any of them become absent in the coagulation cascade, your coagulation cascade won't be completed. No clot will be formed. That's why it is called essential clotting factor. And just see, liver produces number 2, and that is vitamin K dependent clotting factor. That's why prothrombin time is seen here. And another one is platelet count. Platelet count will be seen here. Guys, this class is gonna be a very long class. All you know that I am very much habituated to take class at a time, 10 hours, 12 hours, 14 hours. I took only 30 minutes or 40 minutes break. So if you give your best, I can help you to make you pass in the exam. And if you can't, then it will be really difficult for you to make you pass. So focus on your understanding so that nothing you can forget in your exam, right? So assessment of the coagulation profile, you will have to go through the 2 things. One is the prothrombin time and another one is platelet count. Now come to the most important, and that is the control of the bleeding. So in case of control of the bleeding, at first These are the some stepwise correction. At first, you'll have to you'll give some pharmacological therapies. Pharmacological therapies includes two choices. First drug of choice is terlipressin. And second line drug is called octreotide or somatostatin. Right. So you gave the patient CQS protocol, you treat the patient CQS protocol, give the blood, corrected coagulation profile, and you have given the patient some drug. So you will have to look for the whether what is the patient's condition right now. So you will give the patient some antibiotics and assess the patient. So if patient's condition is not improved, so no improvement, then next step is go for the endoscopy. So what are the endoscopic therapies? At first, endoscopic therapy is divided two portions. One is sclerotherapy. And second one is variceal band ligation. Okay. So what we really use in sclerotherapy, the agent, one of my have been asked, what will you use as a sclerotherapy? One is 100% alcohol, or what were you saying, doctor?
Sodium tridicyl.
Exactly. Another, you are saying that another ethanol amine oleate. Ethanol amine oleate. These are the sclerotherapies. These things are given in the, are injected in varices or directly to the varices or paravaricial spaces. Or you can combinedly give the paravaricial space or varices together. So weekly 6 to 8 session is usually done. Weekly 6 to 8 sessions of sclerotherapy is given. Now come to the band ligation, and always remember this is the gold standard. And maximum 6 times can be performed in a single session. You can give 6 bands at a time. Okay. So after that, after finishing the sclerotherapy or band ligation, you will assess the patient. If the patient is improved or not. If the patient's bleeding is stopped, you can continue the pharmacology therapy. Bleeding stopped. Continue pharmacology logical therapies. Continuous pharmacological therapies for minimum 5 days. So if bleeding is not stopped yet, what will happen? So our next step to give the patient some tamponade, and that is called Minnesota tube. These are the steps. So I will teach you, or I will will let you know how Minnesota works at the end of this topic. So Minnesota is given Still no response. No response. Still no response. After giving the Minnesota tube, there is no response. Then your next step is nothing but that is called tips or shunt surgery. Tips or shunt, and this is the last step of the treatment of the management. So now I'll come to the what is the surgical options. So what is the surgical options? Number one, that is called portosystemic shunt or transjugular intrahepatic portosystemic shunt or portosystemic shunt. I am just discussing what are the surgical options. So number one is the portosystemic shunt. So what is really done in case of liver cirrhosis? Just have a look here. This is a liver, and I was saying this is the portal vein, and this is the inferior vena cava. So what happens in the liver cirrhosis? The liver becomes cirrhotic. No blood can go from the portal vein to here. So portal pressure is increased. So our surgical option is transjugular intrahepatic portosystemic shunt. Transjugular intrahepatic. So through the jugular vein, a catheter is inserted. Then by Sillinger pathway, the catheter is run up to this way, and here the hepatic vein is here. So hepatic vein is here. There's 2 to 3 hepatic veins remains here. So what is really done? A stent is inserted through this way, and through the hepatic vein, the stent is just completely anastomosized with the portal vein by piercing the liver. So what will happen? The blood is come this way, and there is no obstruction right now. Though those things won't come to the liver and liver vein, blood will directly go to the inferior vena cava through the stent, and that is called transjugular intrahepatic portosystemic shunt, because the stent is inserted into the jugular vein, then stent is passed to the liver, transjugular intrahepatic portal. This is the systemic vein, inferior vena cava is the systemic vein, and this is the portal vein. That's what called portosystemic shunt. So is there anyone who can mention the name? What is said? Transjugular intrahepatic
Intrahepatic portosystemic shunt.
shunt. Right. So this is the way how portosystemic shunt works. Now come to the another surgical option. This is called stapled esophageal transection. Esophageal transection. So what is done really here? At first, gastric vein are ligated. Gastric vein are ligated. Definitely left gastric vein. And distal part of the esophagus is transected. Distal esophagus is transected, and it is anastomosized with the cardiac end of cardia of the stomach. Distal esophagus is transected plus anastomosized size with cardia of stomach. So our main problem was the left gastric vein dilatation. So now this vein has been stapled, this vein has been ligated. The esophagus, this is where the vein is soiled up. Distal esophagus is the resected, and the rest of the esophagus is anastomosed with the cardiac of the stomach. So this problem or varices become corrected. This is so this portion is called esophageal stapled esophageal transection. And the last, so still there is no hope, and the last step is to liver transplant. And these are the stepwise treatment of this patient, liver cirrhotic patient. How would you manage the patient?
Doctor, there is any role of splenectomy?
No, no,
Need
no.
of any
After
no
splenectomy,
need.
the thing will remove the consequences of the hypersplenism. So, because in case of hypersplenism, you know that the patient will have pancytopenia, hypo or normal cellularity of the bone marrow. This thing will the consequence of the hypersplenism. So, just the condition will be improved, nothing else. But the main surgical treatment is this thing that I have mentioned here. So, would I go again throughout the topic to have a quick recap? So, regarding the management, we have classified the management into three portions. One is active management of the bleeding. Second was assessment of the coagulation status and control of the bleeding. So, active management, all those things we will usually do in case of any large bleeding. These are the oxygen therapy, definitely care of critically surgical patient protocol, to variable blood cannula, full blood count, blood transfusion, so many things. Assessment of the coagulation status, as the patient is liver is cirrhotic, prothrombin time will be impaired, platelet count will have to see. I will talk to you later on why platelets is decreased here, and ultimately goes to the control of the bleeding. So at first we'll use the pharmacological therapy, and there's just two types of drugs. One is telmipressine, and another second line drug is octreotide and somatostatin. This thing, what is the role of this drugs? Can you tell me? Could you tell me, anyone? The role of this drug, these are the vasoconstrictors. So bleeding will be decreased. Exactly. Exactly. So antibiotics, excess no improvement, ascites no improvement. Then our second step is go for the endoscopy. There's two rules. One is band ligation, definitely is the gold standard. And sclerotherapies, what are the agent we use in the sclerotherapies, and how many times we can give this. I have mentioned that. Then the bleeding stopped, continue the pharmacotherapy. Is the bleeding is not stopped, our third step is the tamponade use, and definitely that is Minnesota tube. If no response still here, then I will go for the surgery, and I have mentioned about the three type of surgery. One is stapled, one is transjugular intrahepatic portosystemic shunt. Is there something else I can help? Transjugular intrahepatic portosystemic shunt, stapled esophageal transection, and the liver transplant is the last option. So
I have a question.
Yes, please.
I have a question. How does the distal esophagus transection help to reduce the bleeding?
Okay, so
why it is needed? Why we need to resect the distal part of the esophagus?
Okay,
Already
so
we have ligating the vessel.
which vessel?
That is
So,
left gastric vein are ligated.
okay, so
So why do we need the
on
resection
that
of the
case,
esophagus?
on that case, we'll have to come to the pathophysiology of the esophageal varices, special esophageal varices, like this one is the esophagus, right? This one is the esophagus. Only and this is the mucosa, definitely. This is the mucosa, and this one is the submucosa. This one is the submucosa. So whenever you will go through the anatomy portion, you'll come to know that the distal, this first one, second one, and third one, distal esophageal venous genus goes to the left gastric vein. This is the left gastric vein. And left gastric vein drain into the portal vein, and ultimately the liver. So whenever there is a liver cirrhosis, the portal vein can enter here. So distal left esophageal vein become engorged, and this vein becomes engorged, this portion, submucosal, definitely submucosal, distal esophageal submucosal venous congestion basically occurs. And whenever the patient is running a long amount time in this situation, the structure of this portion becomes distorted, and definitely the venous genus is the left gastric vein. So whenever you ligate this thing, and this portion has already been distorted because of the esophageal varices, because this portion becomes disfigured. So it is called that if you remove this portion, that will have a more outcome if you just correctly anastomosis the this portion with the cardia of the stomach. So So one question will be asked in your exam, where the esophageal varices exactly develop from which portion, which layer of the esophagus, and that is nothing but submucosal venous portion. So, Doctor, which was that, Dr. Riaz Bhaiya?
Yes.
Did you get your
No,
question?
I'm Dr. Fahim.
Okay, Dr. Fahim, did you get your
Yes,
question?
I got it.
Okay,
Yes,
that's
yes,
great.
I got it.
Okay, that's great. So, we got our management here. So now you will come into another question. As I was just saying, the patient will have to go through the coagulation profile. So, cause of the thrombocytopenia in this case, why thrombocytopenia occurs here? Number one, spleen is called reservoir of platelet. Reservoir of platelet, and you will be surprised. Normally, 60 to 70% of our whole platelet remains in the circulation, and rest 30 to 40% remains normally in the spleen. So whenever the patient will have a hypersplenism or enlargement of the spleen or splenomegaly, the more platelet will goes to the spleen when spleen capacity of the spleen become enlarged. So patient will have less platelet in the circulation, and this is one stem only. Second stem, as the patient is having bleeding, for stopping the bleeding, his coagulation cascade will be started, and ultimately, whenever I will teach you about the DIC, the conception will be very clear, because DIC itself will take 30 to 40 minutes. So I will not go on that side. So just remember, when a huge amount of bleeding occurs, that ultimately ends into the DIC. And in case of DIC, breakdown of platelet occurs. Then number 3, liver produce a such kind of hormone that is called thrombopoietin. And the role of the thrombopoietin is called increase platelet. Thrombopoietin basically stimulates the interleukin 6. Interleukin 6 stimulates the liver produces the platelet. So as the thrombopoietin can be produced, basically as the thrombopoietin can be produced, so thrombopoietin can produce any platelet. Or the main thing I'm just saying you then, any infective condition or any condition, a pro-inflammatory cytokine that is called interleukin 6 is produced. Interleukin 6 stimulates the liver to produce thrombopoietin, and thrombopoietin ultimately stimulates the platelet count. So as the liver is distorted or the liver function is altered, so no thrombopoietin can be produced, and as the thrombopoietin can be produced, no platelet will be produced on this reason. Did you get my point, doctor?
Yes, sir.
Yes, Bhaiya.
Okay. So in that case, whenever we'll give the patient some blood for the management, we'll follow some protocol that is called, what is called? Massive transfusion protocol. Massive. This is the starting of the treatment. This is the CRISP protocol. But whenever we'll give the patient some blood, that is called massive transfusion protocol. That is called massive transfusion protocol. In case of massive transfusion protocol, we'll give, in case of massive transfusion protocol, we'll give some RBC, plasma, and platelet. And everything is 1:1:1, right? And this is called massive transfusion protocol. So if you want to write it here, you can write it down from those portions. So the examiner will ask you, after finishing this portion, what are the indication of platelet transfusion? So what is the indication of platelet transfusion in this patient? Could you tell me what is the indication of this patient?
As the platelet count is decreasing due to
Yes,
liver failure.
one of the platelet count has already been decreased due to the patient is having liver disease and the patient is having ongoing coagulopathy or DIC, and another one is will give the patient some massive blood,
Protocol.
and as a massive blood transfusion protocol will give the patient some platelet. So this is the two option why you will give the patient platelet. So did you get my point, doctor? Did you get my point? Sorry, the
Yes.
next question. Now come to the next question. The examiner will ask you how alcohol causes liver cirrhosis. We have already discussed about the liver cirrhosis, but right now I would like to tell about the alcohol metabolism, and this is the most important topic, one of the most important topic in this portion, and definitely the examiner will ask you, and it's very tricky, I think. So if you do have a crystal clear knowledge, so this thing will become very easier. Alcohol metabolism. In case of alcohol metabolism, at first, whenever alcohol the patient consume, the alcohol become acetaldehyde, 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 acetaldehyde. And an enzyme works here, and that is called ADH. The full form of ADH is called alcohol dehydrogenase. Alcohol dehydrogenase. So this alcohol is converted into acetaldehyde by alcohol dehydrogenase, and acetaldehyde ultimately converts into acetate. And there's another enzyme is called ALDH, which helps to convert aldehyde to acetate. And one enzyme helps here that is called ALDH, and the full form is acetaldehyde. Acetaldehyde. This will definitely ask in your exam. Just try to remember acetaldehyde dehydrogenase, one enzyme, and another enzyme that works here, and that is called catalase. So what are the things we found here? Alcohol converts into acetaldehyde. Acetaldehyde converts into acetate. For the conversion of alcohol to acetaldehyde, one enzyme works here that is called alcohol dehydrogenase. And I forgot to mention that another enzyme that is called cytochrome P450. Cytochrome P450 helps here. So how many enzymes we found here? One enzyme, alcohol dehydrogenase. Please mention someone. One enzyme, alcohol dehydrogenase.
Alcohol dehydrogenase, cytochrome and P450.
Exactly.
And catalase.
It converts alcohol to acetaldehyde.
Acetaldehyde.
And acetaldehyde converts into acetate by the help of acetaldehyde dehydrogenase, and catalase also helps here. So in your exam, you'll be asked by the examiner what are the enzyme or how alcohol metabolized in the liver. So you'll have to mention the name of the enzyme. The name is cytochrome P450. It is also called microsomal ethanol oxidizing system or MUOS system. Another one is alcohol dehydrogenase, that might be alcohol dehydrogenase and acetaldehyde dehydrogenase, and the catalase. These are the enzymes. So by this way, alcohol become metabolized. But if this alcohol, another role of this alcohol, when alcohol goes into the body and the liver is alter the normal function of the liver, what is really do? It will decrease VLDL. So what is the function of the VLDL? Could you tell me, anyone?
Transport TG and private acid From liver to
it transfers exactly, Doctor. Nice thing. It
Liver to
transfers the
periphery.
fat from the liver to
to the periphery.
exactly. It transfers
Liver to periphery.
fat liver to periphery. So alcohol alters this pathway, so decrease VLDL. So will the liver able to transfer the fat from the liver to periphery?
No.
So decrease transfer of fat from liver to periphery. So what will happen? The liver will be mass of fat, and that is called fatty liver disease. Fatty liver disease is the one point, and that is called fatty liver disease. Did you get my point, doctor?
Yes.
Yes, sir.
Okay. So
Doctor,
now
cytochrome P450 is called microsomal
Muse brother, microsomal
Muse.
ethanol oxidizing system, Muse system.
Okay.
There is another name of this one, and definitely this expressed as CYP2E1. CYP2E1. So our first step, what is the consequences, how liver cirrhosis occurs after the alcohol consume? Particularly, we are discussing about this portion. At first, we come to know that how cirrhosis occurs generally, but right now, at first, we come to know the metabolism of the liver and metabolism of the alcohol and the consequences of the chronic alcohol consume. One is the first conversion is the fatty liver disease. So if the patient continuing to taking the alcohol causes release of some reactive oxygen species and some cytokines. If the patient continues taking the alcohol, it will increase the reactive oxygen species and release the cytokine. So what is the reactive oxygen species? Is there anyone know? Free radicals. What is the role of the free radicals or the consequence of the free radicals? Isn't there anyone who can mention? Free radicals
Cell
directly
injury.
damage, exactly,
Cell injury.
damage the DNA damage, directly DNA damage or cell injury. Very good. What's that? Doctor?
Bhaiya nahi tha.
Okay, that's great. And one is damage to the DNA by secreting reactive oxygen species, and another function, it activates the Kupffer cell that is present in the liver, that is macrophage or Kupffer cell. Kupffer cells. So when Kupffer cells become activated, the Kupffer cell will produce some cytokines, right? Cytokines, as it is a macrophage, it will produce some cytokines, and definitely these cytokines are going to lead to inflammatory activation of the inflammatory process in the liver. So whenever inflammatory process with the liver, and if inflammatory process becomes continuous and chronic inflammation, the stellate cell will again become activated. And what is the function of the stellate cell? What does the cell release, doctor?
Transforming growth factor beta.
Beta 1. Very good, very good. Transforming growth factor beta 1, and ultimately it will causes fibrosis. So definitely you will be asked in your exam what is the metabolism, how alcohol become metabolized, what are the enzymes that are responsible for the metabolism, what are the consequences of the chronic liver consume, how it causes fatty liver disease, how it causes liver cirrhosis, and those are the things will be asked in your exam. Is there any question, doctor? Is there any question, doctor? So
No, Bhaiya.
okay, that's great. Then you will be asked in your exam, how ascites occurs in your ascites occurs here. So we have already mentioned that how ascites occurs here, but you will have to come in a proper knowledge with ascites. We'll discussing about ascites. At first, come into the increased pressure in portal vein, right? Portal vein. What is it? Start by this way, portal vein. Increase pressure in the portal vein. So whenever portal vein pressure increase, nitric oxide is decreased or increased?
Nitric oxide increased.
Increase nitric oxide. So whenever nitric oxide increase, blood flow to the abdominal vessels is increased or decreased?
Decreased.
Increased.
Abdominal vessels. All the other vessels. So whenever blood increases in the abdominal vessels, renal perfusion is decreased or increased?
Renal perfusion decreased.
Renal perfusion decrease. So renal perfusion whenever decrease, the renin angiotensin is increased or decreased?
Increased.
Increased. So whenever renin angiotensin allocation increase, the sodium retention increase or decreased?
Sodium increased.
So just have a look here. When the portal pressure is increased here, nitric oxide synthesized here, abdominal vessel will take more of the blood, so renal hyperperfusion, renin angiotensin is increased, and sodium and water is increased. So in this way, whenever there is a chronic obstruction or chronic liver disease, in case of liver cirrhosis, the blood can't drain the blood. That's why there is a portosystemic shunt, right? I have already mentioned there. So whenever you will come to know that whenever there is any obstruction of any vessels, chronically there is production of the some new vessels by the process of angiogenesis, right? So around these vessels, there will be production of the some new vessels, and collateral circulation will increase here in this liver cirrhosis, right? Because no blood can go into the liver, so this vein is trying to lose its blood and it goes to the portosystemic shunt. So definitely there will be some angiogenesis to overcome this process, and the venous circulation will increase here, right? So whenever renal circulation or collateral circulation or venous circulation increased here, the lymphatic supply or splanchnic lymph will increase here. So increase splanchnic lymph, splanchnic lymph. So we have already mentioned that decrease albumin. So whenever albumin is decreased, colloidal osmotic pressure is decreased. So blood fluid seeps in peritoneal cavity, and ultimately renal angiotensin allocation system is caused the increased blood pressure and release of the fluid into the free cavity. So these are the causes of the ascites in a chronic liver disease. So did you get my point, doctor? Please just mention, did you
Yes,
get
sir.
my point? How ascites occurs? There is a formation of the hepatic splenic lymph due to portal circulation, the hypoalbuminemia, and for the renin angiotensin allocation system, there is some retention of the salt and ultimately increase the blood, salt, and water in the body. So, is there any confusion?
Can you please tell about the splanchnic lymph again?
Yes, definitely. So, I was just saying that this is the liver, and this is the portal vein. And as liver is cirrhotic and this is a systemic vein, then ultimately goes to the inferior vena cava. So there is a shunt vein goes this way. So when there is a chronic obstruction, as the liver has already been cirrhotic, so there will be some new vessels will form around these veins, and by the process of angiogenesis, so venous system forms here, and you know this, there is some lymphatic vessels forms along the venous systems. So lymphatic supply, or sorry, lymphatic, as there is a port, as there is the obstruction, so still there is some veins is formed here. So this thing can go directly to this way, and that's why few things will seep here, and this is the cause of the uh, production of the what is said. Uh, what is said? We are just
Splanchnic,
splanchnic
splanchnic
nickname.
limb.
This is called splanchnic nickname. So main thing is there is a formation of the new veins. There is a formation of the new veins, and there is an obstruction. So veins can be drained to the liver, and that's why, as there is some obstruction, those things come out from the vessels, as there is a portal hypertension. So did you get
Okay, I
my
got
point?
it.
Okay.
Yes.
Main thing is the new vessels, collateral circulation, the key. Always remember this. These things is really difficult to understand, but you will have to just mention the collateral circulation or new vessels. Now the examiner will ask you, just tell me why confusion occurs in this type of patient.
Hepatic encephalopathy.
Okay, that's great. Now I would like to say the patient will have some nutritional deficiency. And what are the nutritional deficiency, and what's the role of the nutritional deficiency? I would like to say about the vitamin B12. Vitamin B12. The alcohol is one kind of substance. Whenever a patient takes any alcohol, the vitamin B12 can be absorbed. Vitamin B12 can be absorbed from our gut, right? So what is the function of the vitamin B12? Right, like it's a RBC. There is so many steps of the RBC. Is an immature RBC, immature, and RBC becomes mature by several steps by this way. Like this one is the poichoblast, basophilic oblast, orthophilic, polytomotophilic, and reticulocyte, and is the mature RBC. So whenever there is a maturation of this RBC, these are the hemoglobin, and this one is the nucleus. So the two factors which matures the nucleus, one is vitamin B12, another one is folic acid. So when adequate supply of vitamin B12 and folic acid is here, these substances will mature the RBC, and when there is a maturation of the RBC becomes divided, and it becomes mature and forms a smaller RBC, and that is almost 7 to 8 micrometer. So if there is an absence of folic acid or vitamin B12, the nucleus can be matured. This nucleus can be matured, and RBC can be breaking down, or RBC can be divided and can to form a smaller RBC or mature RBC. So when there is an absence of or deficiency of the vitamin B12, like the patient is having alcohol, the vitamin B12 can be absorbed in our body, and as there is an absence of vitamin B12, the nucleus can be matured, and this can convert the RBC into the mature RBC. That's why patient will have what is said, megaloblastic anemia. Which type of anemia? Megaloblastic. Okay, now come to cell cycle. Especially you will ask in your exam on which step will be altered by the absence of the folic acid. There is so many steps in the cell cycle. One is M, another one is G1, another one is S, another one is G2, and that it comes to the M. So the M is for mitosis. The G1 is for the growth. So the S1 is for the DNA synthesis, and G2 is also G is for growth plus preparation for next step. What is the next step? What is the next step?
Mitosis.
Mitosis. So what will happen? Just whenever the patient is lack of vitamin B12, this step will be blocked. Which step, doctor? Which step?
Preparation for mitosis. G2.
Exactly, G2. G2 cannot progress from the G2 to M. So the cell will stop here and that can go for the next step. So this step will be blocked. So G2 to M phase will be blocked. So cell become mitosis. There is no mitosis, so cell will be larger, and that is definitely called megaloblastic anemia. And whenever the size of the cell is more than 100 femtoliter, and that is called megaloblastic anemia. Is there pin to here? Is there Pinto here? Dr. Pinto, are you here?
জি জি ইসব ভাই
Are you
হ্যাঁ
getting
শুনতেছি
the topic, doctor? I don't know
জি জি জি
that
সেল
you are,
সাইকেল ইয়েস ক্লিয়ারলি
guys, are you understanding me or not? Please let me know, because it's the first day of the class. I am trying to make very easy to you, but I'm not getting any
জি
feedback
জি ভাই
from.
all the mechanism firstly you describe all the mechanism so and now we learn all the things
Okay,
when
then
you
when
describe a
will
clinical
come.
finding we can really correlate this with your pathology
Exactly. Whenever we'll go to the
what's happened now
main
yes
book, you'll be surprised that all the thing we have been gone through already. So
I
what is
think
the
yes
what is,
Rifat bhai, this is I think this is the easiest way to understand any topics
thank you,
and
brother. So
any finding any mechanism
yes, thank you.
yes
So in case of follicle deficiency, which step is blocked? Dr. Anchal, which step is blocked, sister?
Uh, preparation for mitosis, like B12.
No, from the conversion of the G2 to M phase, this step is blocked.
G2 to M. Yeah.
Exactly.
Preparation for mitosis. That's what I was saying. Sorry.
Yes.
G2 to M. Yeah, I should have
Yes.
said G2 to M.
So is this step is blocked, so cell can't be broken down or cell can't be divided, and cell can be converted into a large cell to a smaller cell. So these cells are become so large, and that is called megaloblastic anemia, right? And is the chronic complication of the chronic alcoholism. So we have come to know that what is the ultimate management
This
of
is
a patient.
Dr. Sir,
Yes, please.
this is from G2 to M. Or
Yes.
B12.
G2 to M phase, bhaiya. G2 to M phase.
phase.
G2 to M phase, this conversion, this portion. G2 to M phase. It can go, the cell is prepared to divide it, but it can be divided into mitosis. Right?
Or which
Okay.
leg? Or which leg of
Which?
folic acid?
No, on vitamin B12, both are responsible, but especially patient who are lack of who are taking alcohol, they lack of vitamin B12 because alcohol can't lead the absorption of the vitamin B12.
Both X here.
Yes, 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 yes. So the examiner will ask you, as your in case of liver cirrhosis, our last ultimate goal of treatment is the liver transplant. Liver transplant. So the examiner will ask you, so how would you counseling the patient's family, especially family, regarding the liver transplant? How would you? So regarding the counseling of the especially in case of transplant patient, will definitely will tell or talk about the patient's condition at first. We'll talk about the patient's condition, why liver transplant is needed, why needed. At first, we'll tell the patient about the patient's condition. Patient's condition is the first step. Then, what are the treatment modalities? Treatment modalities will be discussed about the treatment modalities, and definitely all of you know liver transplant is not a easy way. There is some chance of rejection. That's why we'll have to discuss about the outcome of the treatment. Outcome of treatment. So at first, this thing all these things goes to the counseling. So first thing is the counseling. Then you will have to mention about the lifestyle modification. Lifestyle modification. Lifestyle modification. So what comes to the lifestyle modification as the patient, why cirrhosis occurs in this patient? Could you tell me why cirrhosis occurs
For
here?
alcohol.
Exactly. So
Alcohol.
there will
Alcohol.
be definitely abstinence of the alcohol. Alcohol for at least 6 months. At least 6 months. And definitely there would be some blood grouping, matching of the blood grouping, AVO matching, RH matching, HLA incompatibility. This thing will be matched, and definitely patient will kept into immunosuppression therapy. Immunosuppression therapy. So all the 4 things we'll have to talk about the patient's family, because these things are the most important thing we'll have to talk about the patient. So is there anything that you would like to hear again, doctor? Then we'll come to the book. Dr. Anava, are you here, sister? Is there anything you'd like to mention?
No, Bhaiya, I understood everything. Thank you so much.
Okay, now come to the book. So
I have a question. Vikas.
yes, please. Yes, please. Who is
In
this?
case of tamponade defect, you mentioned tamponade menstrual tube.
Yes,
What is the difference
I discuss about the temporal because it's a very important tube and it is usually very randomly used in UK. I'm just coming to tamponade just later on. Just come to the book right now. So what are the concern about the patient? We have discussed everything. What are the differentials? We have discussed everything. How to manage the patient? I have discussed all of those things again. So I just wrote the stepwise management of the patient. So try to manage this thing, arrange those things here. Stepwise management is very important. So what are the role of endoscope? Esophageal varices, there is some role of endoscope. One is diagnostic therapy, another one is therapeutic therapy. So just diagnostic therapy is the real vision, is the recall question, is the real vision, and therapeutic studies, just sclerotherapy, injection sclerotherapy, band ligation is the most important. Another other of this thing. Apart from these 2 things, there is a coagulopathy, hemostatic clips, and apply hemostatic spray. And this is the recall question. So what are the causes of thrombocytopenia in the patient? Could you tell me why, what are the causes of thrombocytopenia in this patient? We have mentioned this.
Massive transfusion protocol and decreased platelet.
Exactly. And another thrombocytopenia and thrombopoietin, DIC, splenomegaly, right? I have mentioned every single thing. Okay. Now, why platelet is transfused here? Could you tell me why platelet transfused here? One is massive blood transfusion protocol, and another one is coagulopathy, right? Which varices are usually bleeding, especially which varices are bleeding? Varices in the submucosa. Definitely will ask you. I draw a picture in the class. Submucosa of the lower esophageal portion of the lower esophageal, the common source of the bleeding, and just write it down. Which vein? From which vein, Bhaiya? Which vein?
Is lower esophageal vein.
Left gastric.
Left gastric vein. Left gastric vein. You'll be asked directly this question, so try to write it down here. So blood finding of the alcoholic picture. So one thing is platelet is decreased. Why platelet is decreased? I have already mentioned that due to alcohol. One is thrombopoietin here. Another one I just forgot to tell that as the patient is having some toxins in the blood, toxins like ammonia, they will directly suppress the bone marrow, and ultimately decrease the production of the platelet. So low platelet due to toxic effect of the bone marrow, impaired hematopoiesis, RBC, another thing. Raise MCV. These are the blood changes. One is low platelet count, raise MCV, and some liver enzymes. We'll discuss all of the thing in our fourth topic today. And what is the pathophysiology of the hypertension in chronic alcoholism? Could you tell me what is the pathophysiology of the hypertension in chronic alcoholism? All of this we have already mentioned here. How basically how potassium hypertension occurs in chronic alcoholism?
Edema in the hepatocyte.
Mm-hmm.
Pressure on the stellate cell, and stellate cell release transforming growth factor
Very
beta
good.
1.
Mm-hmm.
This causes release matrix.
Mm-hmm. Extracellular matrix.
Extracellular matrix compress the portal.
Extracellular matrix, and it ultimately causes fibrosis and compress the portal vascular, and there is a resistance in the vessels, and so flow is impaired, so there is a production of the portal hypertension. That's good, very good. So surgical treatment, therapeutic management, surgical treatment is a portosystemic shunt, transjugular, intrahepatic, portosystemic shunt. I have mentioned that. Staple esophageal transection, orthosteric liver transplant, right? So what is the tips? I have already mentioned that is this stent is inserted through the which vein? Which vein, bhaiya? Which vein, Apu?
Internal jugular vein.
Exactly.
Internal jugular vein, supravena cava, infravena cava, middle hepatic vein.
Exactly. Supravena cava, infravena cava, then hepatic vein, and this is the portal vein. So directly liver is pierced and the stent is passed into the portal vein. So there is no obstruction, just portal blood directly goes to the stent and goes to the through the hepatic vein, goes to the inferior vena cava. So by this way, this is overcome. There is some purpose and mechanism written here. What are the indications? That is also written here. Ascites, and another one is vessel clearing. How alcohol causes cirrhosis? I have already mentioned here how alcohol causes cirrhosis. Some lipid metabolism, reactive oxygen species, some cytokines, inflammatory process, ultimately stellate cell proliferation and causes cirrhosis, and ultimately causes liver. So cause of the confusion of the patient, hepatic encephalopathy. What are the hepatic changes of a consequence of the excessive all alcohol consumption? Fatty liver disease, then steatohepatitis, just hepatic fibrosis, cirrhosis, and ultimately hepatocellular carcinoma. The thing we have mentioned here, just the thing we have mentioned here, and this is the steps. Basically, this is the steps we have mentioned here. What are the enzymes works there, and also consequences like this: the fatty liver disease, reactive oxygen, cytokines, the inflammation, the liver cirrhosis, and what is the DNA damage? DNA damage, and during the DNA damage, there is a and damage ultimately lead to hepatocellular carcinoma. So whenever you go through this thing, you will come to know this is the recall question. You just have to know this. How is alcohol metabolized by the liver? Is there anyone who can mention how how liver become metabolized in the liver? I think our class will take more 3 to 4 hours more.
Alcohol becomes acetaldehyde with the help of ADH and cytochrome P450, and then acetaldehyde is converted to acetate with the help of ALDH and catalase.
Exactly, very good. So what are the enzymes these are responsible, sister?
Alcohol dehydrogenase and cytochrome P450 for the first step from alcohol to acetaldehyde, and acetaldehyde dehydrogenase and catalase from acetaldehyde to acetate.
Very good. So this enzyme is also called cytochrome P450 or Meuse enzymes, alcohol dehydrogenase catalase, right? Mechanism of ascites formation, obstruction lymphatic drainage, ability to lymphatic system drain into the peritoneal space, increased formation of the hepatic and splanchnic nerve due to collateral circulation, new venous or angiogenesis, I have already mentioned, hypoalbuminism due to liver cirrhosis, liver damage, and RAS system, I have already mentioned that. Cause the confusion liver, again, patient with macrocytic anemia, the what will be the cause? I have already meant due to vitamin D12 deficiency. How vitamin B12 deficiency causes macrocytic anemia? On which step is blocked?
Maturation of nucleus of the RBC.
Which step, which step is blocked here?
G2 to M.
G2 to M conversion, right? G2 to M conversion. That's why a large immature RBC can't convert into 7 to 8 micrometer RBC. So RBC, whenever RBC become mature, it becomes smaller step by step. So how would you counsel the patient? I have mentioned that. Now come to the Sangstein Blackmore tube. Who wanted to know about this one?
Sangstein Blackmore and Minnesota tube.
Exactly. So you wanted to know the difference. So at first, just know what are the indication why we insert the Minnesota tube or Sangston Blackmore tube. Why we insert this one? At first, indication is acute life-threatening bleeding from the esophagus or varices. Then come to that, there is no response to medical therapy. I already talked about the medical therapy, including endoscopic hemostasis or vasoconstrictor, telmipacine, or octreotides or other drugs. So these drugs is not working, first thing. Then endoscopic hemostasis and vasoconstrictor therapy are unavailable. So you tried endoscopy or tried pharmacological therapy, these are not working, and these things are not available. So these are the indication of the insertion of this tube. So at first you will always, so many of the people are confusing about the about this tube. At first, always remember, just write it down. Sangston Staken Blackmore tube is one thing. They have three tube or three opening. Whenever you add another opening, that is called esophageal opening, and that is called equally Minnesota tube. So the main thing is Minnesota tube is nothing but a modification of the Sangston Blackmore tube. Sangston Blackmore tube has three opening, but if you add another opening with three opening, and that is called esophageal opening, and that is called Minnesota tube. Did you get my point, doctor? All of you will confuse. If you don't understand right now, you will confuse this thing later on in your whenever you are going to go this thing. Just at first, just know what is the difference between the Minnesota tube and Sangston Blackmore tube. What is the difference? Main difference. So how many are
Esophageal opening.
exactly?
One has
So
3 opening and another one has 4 opening.
yes, whenever you will add Sangston Blackmore tube with esophageal opening, and that is called Minnesota tube. So if there is no Minnesota tube, or if there is no Minnesota tube is available, or if opening of the esophageal tube is available, the patient is the doctor or nursing doctor or whoever is responsible, he do have only Sangston Blackmore tube. So you can just add NG tube, then it will work as it works as a Minnesota tube. So whenever there is no Minnesota tube, if you want the as the function of a Minnesota tube, just add NG tube with which tube, doctor? Which tube? Sangston Blackmore tube. Right.
But
Now come to the
when
picture.
the NG tube, I have a
Yes.
question.
Yes, please.
So if we do insert an NG tube with the Blakemore tube, so the NG tube must be inserted just up to the esophagus, right?
Yes. Just to I am coming to this point right now. Wait for a while. So at first, this picture, come to this picture. This is itself is a Minnesota tube, because there is two balloon. One is gastric balloon and another one is esophageal balloon. And there is two opening. One is gastric aspiration opening, and these are the opening, and another one is esophageal opening. If there is no opening here, then or absent of this tube, then it would called as Sangston Blackmore tube. But if the opening is right now present and there is a two opening and two balloon, now it is called Minnesota tube. Did you get my point, doctor? What is the difference between the Minnesota tube and Blackmore Sangston tube, Sangston Blackmore tube? So Minnesota tube is nothing but a modification of the Sangston Blackmore tube. So what's the technique? How would you insert this tube to the patient? At first, just now down to the technique. At first, you will keep the patient in 45 degree, then anesthetize the posterior pharynx plus nostril anesthetize. Then take the tube and lubricate the tube, lubricate with lubricant or Jesocaine. Then you will have to insert the tube through the nostril. Which opening, doctor? Nostril up to 50 centimeter. 50 centimeter. Then give suction through the one is esophageal to remove the blood that are present in the esophagus, and another one is gastric suction. So after giving the suction, you are confirmed that your tube has already been sent in the stomach and the lower portion. Then you will inflate the gastric port, gastric balloon with 100 ml of air inflation. So come to this picture. This is the gastric balloon and this is the esophageal. So after insertion of the 15 centimeter, is the 15 centimeter, and you give two suction. One is the gastric aspiration and another one is esophageal aspiration. You understood? The patient, this thing has rest in a proper position. Then you will inflate the balloon with 500 ml of air. Then retract the catheter to outside, and this balloon will be stuck here against the diaphragm, because this is the at the thoracic 12 level, it pierces the diaphragm. So when you will retract this portion, it won't come outside. So you will fix this portion. So there is a traction here against, and so gastric balloon will be stuck here. So there will be continuous traction here, and it has already been traction is already been given here, and the esophageal balloon. Then your next step to inflate the esophageal balloon. And remember, it's a very crucial and very important, because you are not allowed to give so many pressure here. You are only allowed to give 35 to 40 centimeter of water or minute of mercury. So what is our next step, doctor? What is our next step? Traction, right? Traction. Are you guys with me?
Yes,
Traction against
in the
diaphragm. Traction against the diaphragm. So when we will give the traction and that will stuck against the diaphragm, then esophageal balloon inflation 30 to 40 or 45 ml of mercury. Then you will assess whether there is any bleeding or not. So if there is no bleeding, just deflate 5 millimeter, deflate 5 millimeter every 3 hourly until it becomes 25 milliliter of mercury. So you inflated is 30 to 40 milliliter of mercury. Then if there is no bleeding, observe the bleeding. If there is no bleeding, then deflate the balloon 5 millimeter every 3 hourly until it becomes 25 milliliter of mercury, because it's the fixed point. You can't go beyond this thing. If there is no bleeding, keep this way for at least 12 to 24 hours for 25 to 25 minutes of mercury. But one thing you'll have to remember, every 6 hourly, we'll have to deflate completely to why pressure necrosis. Necrosis. Just 6 hour interval, you will have to deflate completely. It will be kept at 25 milliliter of mercury for at least 12 to 24 hours. But always remember 6 hourly you will have to deflate it at least for the 5 minutes. I just forgot to mention 5 minutes to prevent pressure necrosis. Are you guys with me? Are you getting my point?
Yes.
Yes.
Okay, now come to the book. So Sangstein Blackmore tube, double balloon tamponade. One is gastric and another one is
Esophageal.
two balloon, right? So port, there's 3 ports usually: gastric balloon, esophageal balloon, and gastric suction. And if there is a esophageal suction, what is the name of this one?
Sort of.
Exactly,
Minnesota.
Minnesota. So esophageal suction port or help suction of the esophageal content, and this is called Minnesota. Sangstein Blackmore tube. Replace these things are written here. If there is no modification, so you do have only Sangstein Blackmore tube, and this question rapidly come very regular basis will come in your exam. So this is a NG section. So insertion of the Blackmore tube we have already mentioned. Why? What are the contraindication? This is a recall question. Just try to correct. Is one is the stricture. If there is any stricture and there is a recent surgery in the esophagus, so you are not allowed to give this thing if there is a stricture or recent surgery. So this is the contraindication. Or what are the complications? There might be aspiration pneumonia, as there is a tube. Even NG tube itself may cause aspiration pneumonia, failure and necrosis, inflation of the balloon. There might be perforation and there may be bleeding. I have mentioned all of the techniques here. Just go through this thing. What are the possible complications as a blood transfusion? Blood transfusion sub complications, just for your own reference. These are the immunological and these are the non-immunological. Just go through the, I will discuss those things later on in the DIC. Massive blood transfusion. When what is called massive transfusion, time is used to when transfusion volume is given within 24 hours, which is greater than or equal to the patient's circulating blood. So there is another definition of the massive blood transfusion. Do you know?
Yes.
Yes, what is called, Bhaiya? Transfusion of
then
50%.
50%.
Exactly. This is another. This is the older one, Bhaiya. This is the older one. 50% within 4 hours, and that is called also massive blood transfusion. Whatever. So try to memorize this one. For the complication of the massive transfusion, these are the directly copied from the Bailey lab, and you will be asked whenever this topic come in your exam. One is fluid overload, another one is coagulopathy, hypothermia, metabolic acidosis. You can omit this one, no problem. But electrolyte imbalance, hyper or hypokalemia, both can occur, and definitely hypocalcemia due to anticoagulant. These are the complications. So I think we finished our first station. So, are you guys with me?
Yes.
Yes, dear.
Are you tired? I am not tired at all. We do have 4 more stations. I will try to cover at least 3 more. We do have at least 3 more stations. So you are already tired. Who are tired? Dr. Anchal from India, right? Are you tired?
I have a big cup of tea with me.
Okay, I warned you before starting the class because all of the classes that will gonna be happen with me, just memorize, try to remember. I will take so many times from you just to complete your studies in the class. So I think whenever you go through the notes I have made today and just go through the topics and